Hi, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. We get this question a lot on being patient. It's one dealing with genetics. People who have family members who have been diagnosed with dementia often ask, should I get a genetic test? What is it going to tell me? I'm afraid to get a genetic test. All of those comments come up time and time again. So we decided to go to one of my favorite Alzheimer's prevention and a research institute, Banner Alzheimer's Institute. We have with us today Jessica Langbaum. And here she has the experience on this topic to tell us about what do we know about genetics, and should people be getting a genetic test? So Jessica, thanks so much for joining us.
Oh, thanks for having me, Deborah. It's great to be here.
So the Banner Alzheimer's Institute obviously interfaces. You have your brain health registry. You interface a lot with people, communities of people impacted by Alzheimer's or who have family members who have Alzheimer's disease. What is the recommendation at Banner? Should people be getting tested to know what their genetic status is?
That's a great question. And I just want to start off by saying I'm not a genetic counselor. I am a researcher who leads research registries and clinical trials, which often enroll people who are at high risk for developing the disease based on their genetics. So some of our studies involve genetic testing and counseling, but I myself am not a genetic counselor. So I'm trying to bring my experience and working with lots of different stakeholder groups on this topic. At Banner Alzheimer's Institute, we don't recommend that everybody goes and has genetic testing to learn about their risk for developing the disease. And you might ask why. And that's because what we know about genetics right now, we know that there are some genes that might increase a person's risk or susceptibility or chances of developing Alzheimer's in later life. But it's just that, it just increases your risk. These are not foolproof tests that tell somebody with 100% certainty that what you will or won't, whether you will or won't develop the disease. And there's lots of other things besides genetics, or in addition to genetics, that influence a person's risk. And so just by learning your people with these genetic risk factors and people without these genetic risk factors develop the disease or don't develop the disease. So right now, it's really just for research purposes that we might have studies that are looking for people with a certain genetic makeup. And that's why we would do genetic testing and counseling, but it's not our standard recommendation for just the general public.
Okay, but we're talking about mainly the APOE4 variant. If you have one copy from one parent, it slightly raises the risk factor. If you have two copies, one from each parent, known as homozygous, it elevates your risk factor more so. But the truth of the matter is, a lot of people are finding out their genetic status through genetic testing kits, direct to consumer testing kits like 23andMe. I found out mine that way. Previously, people had been surprised to get not anticipating the result. So if it's not recommended, I'm assuming now there are people who are finding out their genetic status who might not necessarily had been seeking it in the first place.
That's correct. Direct-to-consumer companies like 23andMe will put up a little box and say, warning, do you want to learn this information? What you're going to learn is about your Alzheimer's risk. And some people say, sure, I'm curious, but they hadn't really thought about maybe all the considerations one should take into account before learning their ApoE genotype or results. And these considerations include family considerations. Learning your own ApoE test, your results might tells your children, your biological children, at least an inkling. If you happen to have two copies of ApoE4, that means your biological children at least have one copy. It might impact, what if you have siblings, what their likelihood will be, or parents. There's financial considerations if you hadn't thought about getting long-term care insurance. So insurance, financial considerations sort of lumped together. So certainly people might click that box on the direct to consumer and say, sure, that might be something I'm interested, but hadn't talked through those things with a genetic counselor. So we're not opposed to people learning their ApoE results, but we really, really strongly encourage somebody to work with a genetic counselor or other healthcare provider who's really knowledgeable in genetics and what this might mean for yourself and your family before you just delve in and click that box and say, oh, I'm curious to learn my results.
Now, I want to talk a little bit about the risk factor because I think there's a lot of confusion around that. For example, I mean, I found out my genetic status. I'm homozygous E3, which is the neutral one, but yet I have a mom with Alzheimer's disease, right? So it kind of goes both ways. Even if you don't have a genetic predisposition, you may very well end up with Alzheimer's. Just like if you have the genetic predisposition, you may not end up with Alzheimer's disease. But we do acknowledge there is an associated elevated risk. Now, in the past, that was to me explained to me as, if you carry one copy, then maybe it's about a 30% elevated risk, and two copies mean maybe over 90%. Is that true? Do we know if that's true? Because I think there's a lot of confusion over actually analyzing the exact risk.
Yeah, there's different ways we can look at this, right? So some of the data that you were looking at were retrospective case control studies that looked at people who came to autopsy and how much, whether there was evidence of Alzheimer's disease pathology in their brains or whatnot. We analyzed in collaboration with Deborah Blacker at Harvard. We undertook an effort to look at several different longitudinal studies, which enrolled people before they might be at the age of risk where they would develop symptoms, and followed them over time to look at, really what is the impact of ApoE, at least by age 85. And, what we found was in this big analysis was that really there's a wide range, number one. And that's telling us that there's a lot of other risk factors at play in addition to ApoE, but the ApoE effect is very real. But for somebody who has two copies of ApoE, and if they are healthy at the age of around 60, that their chances of developing mild cognitive impairment or dementia due to Alzheimer's disease through age 85 is around 30 to 55%. That's a big range, but it's certainly not 90%. And there are numerous cases of people who have those who are homozygous for ApoE4 who never go on to develop Alzheimer's disease, but there are plenty who do. And so that's where that's where we're getting that 30 to 55% risk. For somebody who has just one copy of ApoE, that same analysis led us to believe that their risk through age 85 is 20 to 25%. And then somebody with the E3, like yourself, is around 10 to 15%. I think it's important to point out that age in of itself is the biggest risk factor for developing Alzheimer's dementia, and then ApoE in addition, and other factors like family history. So there are people, your mom might have been an ApoE 3-4,
Yeah.
and you got the 3 from her and 3 from dad.
Yeah, it's interesting as we discover more about our genetics. And, I'm appreciative that you've taken a different type of look into the risk factor there because, I think when people were hearing, 30, 90, that's very scary. Understandably, that's really a scary thought. Now, in terms of research, though, it's pretty important to isolate the people who are E4, right? I mean, they're a very valued community for scientific research and finding a cure for Alzheimer's.
The E4 is particularly those who have two copies of E4, which represent about 2 to 3% of the general population. We're extremely interested in studying this group because there might be help us develop some therapies that target ApoE, and that could be of very interest. In addition, there's another ApoE variant that we haven't talked about, and that's the ApoE2 allele. And it turns out that that is likely very protective, especially if you have two copies of ApoE2. So you're homozygous for the ApoE2 allele. That's about less than half of the general population, but that seems to be, again, very protective. And so studying sort of the bookends of ApoE, your two twos and your four fours, I think is really going to be where we're headed in the next few years with research, and not only better understanding the disease, but identifying therapies to
You
stop
know,
or prevent the
I've
disease.
actually never met anyone who's told me they're E2.
Very rare, but some of our there was a big paper that came out by with Dr. Eric Ryman from our institute earlier this year, was looking at the protective factors of ApoE2 too. It's really quite striking, along with ApoE44.
Right. Now, just for the sake of clarity, we're talking, when we're talking about APOE4, we're talking about later onset Alzheimer's. We're not talking about early onset. Early onset Alzheimer's, they're in a different genetic class. In fact, it's much more definitive in some ways with early onset, because if you possess several genetic variants that have been identified, then you are definitely going to have early onset. So is that right with the
Pretty
APP
much. Yeah. So
one?
there's autosomal dominant early onset Alzheimer's disease, and that's caused by one of these rare genetic mutations on the presenilin 1, presenilin 2, or APP gene. And it's very rare. It counts for less than 1% of all cases worldwide. But if you happen to carry this genetic mutation, you are basically at 100% certainty to develop the disease, typically at a very young age. And it's hereditary, so it's coming down generation after generation, this clear hereditary pattern. I say almost definite because there was a very rare case that we published, some of our group published in collaboration with the team at the University of Antioquia and Medellin, Colombia, and Harvard recently, which there was a presenilin 1 mutation carrier who hadn't yet developed symptoms in her 70s. And when they did a PET scan, her brain was full of amyloid, but there was no tau tangles. And it turned out not only was she a presenilin 1 mutation carrier, but she was homozygous for a very rare ApoE variant called the Christchurch mutation. And so there's something about this ApoE variant that was protecting her brain from developing those tau tangles. And so that's another avenue. Getting back to that ApoE, about ApoE, some variants being very protective. Unfortunately, this woman just passed away recently, not due to Alzheimer's disease, but she had cancer. And so this was nicely covered in the New York Times last week. Highly encourage your readers to check it out. But this story of how ApoE might even be variants of ApoE are protecting the brain against this presenilin 1 mutation is really quite remarkable.
Well, I mean, there's so much more we need to learn about our genetics. And, we just interviewed Claudia Kawas, who's doing the 90 plus study, which is taking, 90 to 100 and past a year old and studying them for a longer duration of time. And one of the conclusions of that study, it's been going on for about 18 years, is that there were people with beta amyloid plaque and tau tangles who didn't show any symptom of dementia at all. They were sharp as anything, sharp as a tack. And then vice versa, there were people who were showing signs of dementia and clearly in a state of memory loss. Yet they didn't, after they passed, the autopsy showed they didn't show any plaque or tangles in the brain. Now, what Claudia mentions is there is a protein that it has been identified in those people, known as TDP43, that was present in these cases. So it's really interesting to see that there are markers out there. And also what Claudia mentioned is what I think you're talking about is resiliency. There are certain patients who are resilient They might have the genetic makeup, but they have something else that we actually don't know that protects them from going into a neurodegenerative state. So I guess what I'm trying to say is it seems like there's a lot more we need to learn in terms of looking at genetics and neurodegeneration.
That's exactly right. And, so I think, from our standpoint, it goes beyond just these basic ApoE variants, the 2, 3, and 4. And as we get into these genome-wide association studies, and our ability to really analyze genetic data and the power of genetics, that's bringing us much further along in our understanding, and how certain genes are protective and some are, risk factors and increase our susceptibility for developing the gene.
What about for the early onset folks? I mean, I think it's possible to have early onset and not have one of the genes, right? Is that
is correct? And so there's a great team of researchers really led out of University of Indiana, or is it Indiana University? I always confuse my Indiana stars who are Indiana folks, leading the study called the LEADS. They're looking at these non-autosomal dominant early onset Alzheimer's cases. So onset before the age of 60. So people are having developing dementia in their 50s or maybe even before. It's not one of these rare. And so remarkable group, and it's a sizable group that deserve and need our study, because I think, again, this is really where some of the genetics come into play. So it's not one of these rare mutations, but it's also not just ApoE. And so that they are really studying that. And I think there's even, in addition to studying these individuals, opportunities to do cutting edge trials with this population. And this is a group that's often excluded from clinical trials and when they're symptomatic because they're too young. And that's just not, we have to stop that.
Yeah, we hear that a lot actually too. It's like you have to be 65 plus. What about the people who are younger, right?
Exactly. So, yeah. And they're and they don't qualify for these autosomal dominant prevention trials because they don't have one of those mutations. So it's what about me? So that's a really unmet need, and that's being studied, and we're really excited where that's going to go.
So I have a question because it comes up all the time on being patient, and that is, when people are asking, should they get a genetic test for Alzheimer's? And you were saying Banner doesn't recommend typically that people find out what their genetic status is. Why not though? Because, in some ways, if we need to identify some of these people because they're so important for research, why not find out what your genetic status is? What are your findings in terms of like maybe the stress that it causes people? Is it, you kind of have to balance those two sides of the equation.
Yeah, so that's a lot of things. So I'll try to unpack it. So, one, we've studied the impact of genetic testing and counseling and disclosure. And what we found so far is in people who step forward and say, yes, I want to learn my genetic results. So that's a subset of people. I call them information seekers. Not everybody's an information seeker. But in those information seekers, when we assess for psychological readiness to receive the results, and what that means is, not actively suicide, not having active ideas about suicide, no major depression, anxiety, things like that. Learning your ApoE results with proper genetic counseling is safe and well tolerated. We'll see a little increase in anxiety and feelings, sort of stress after the counseling, but that usually dissipates and goes back to normal within 6 to 12 weeks after the session. So it is safe. Now that's in people who want to learn the information. One thing I did want to, but that's with genetic counseling. And so, I think when we say the reason why we don't recommend, I think it's multiple things. Probably it's past of, some sort of paternalistic, oh, you don't need to know. It was also, what are you going to do with this information? There's no change. We can't treat you any differently. There's no therapy for you to take. The healthy lifestyle interventions are things everybody should be doing. You should be dieting, exercising, regardless of your ApoE results, because we know, again, everybody's at risk for developing Alzheimer's disease. It's not just based on your ApoE. And I think part of it is also, again, the push for having you do it with a genetic counselor or healthcare provider. And frankly, there aren't enough of them. I mean, that is the sad truth.
So, Jessica, when you, let's say somebody is participating in a clinical trial at Banner, and obviously you're testing their genetic status in a lot of those cases, does the participant get to find out what their status is?
And that varies by study to study. So some studies, yes, everybody is learning their ApoE results, and other studies not. And that has to really be balanced and kept the same within a study. And the reason is, and we're studying this, is this concept of stereotype threat. Think of it like, oh, I'm a woman, I should be bad at math or science. You know, that sort of idea in your head of because of this characteristic of myself, I'm not good at something. And there have been a few studies that show that people who learn their ApoE results all of a sudden not only think worse, think that they're doing more poor, they should be doing worse on tests of memory and thinking, but they actually do. So their subjective belief about their memory and thinking ability goes down, as well as objectively on their test performance, they start to decrease. So that can really impact a clinical trial or other study if some people are learning it and some people aren't in a controlled way. So it tends to be an all or nothing. We're studying this concept of stereotype threat a bit more to see if that's really, really, how real that phenomenon is, and if it's a true threat, or if it's like when you learn your ApoE results, you see a slight uptick in distress, maybe you see a slight uptick in, oh, my memory should be worse, and then it goes back down. We're very surprised. I think that clinical trials and studies are changing, and people should know the information. It's not fair for researchers to know it and participants not, but we have to bring the field and everybody within the study along with it. And for some people, the requirement to learn is a non-starter. Again, it's those information seekers versus non-seekers. So there's a lot to it about why we do or don't do it.
Jessica, enlighten us. We've done some stories on this on being patient, but there's a lot more being discovered with genetics. And we've covered, I think, some other genetic variants that have more of a protective quality. How much do we know about these newly discovered? I mean, a lot of the science is very new. So is there anything out there that we should know about, that Banner knows about, in terms of, unmasking the secrecy behind our genetics, or the unknown, I should say?
Well, again, there's those protective factors. So I think some of this goes back to the Icelandic mutation and seeing that people who have this protective APP mutation, they have it's almost like a natural beta secretase inhibitor going on, and that led to drug development. And so I think what we're discovering now with things like the protective factors of ApoE2 or this Christchurch mutation are going to lead to drug discovery or treatment options. And there's a lot more to come. Again, thinking about Claudia Kawas's 90 plus study and what we're going to learn from those and how we translate that into treatments and gene therapies or things of that nature. There's a lot of really exciting things coming down the pathway, we think, with particularly ApoE targeted therapies.
Great. Well, thank you so much, Jessica Langbaum, and to Banner and all of the great work that you guys are doing for Alzheimer's research. And, please make sure you come back and tell us more when there are new findings, and to keep our community abreast of the latest.
Well, anytime. We love being patient, and we love all the information that you're putting out there, and we think you're just a great resource, and so happy to be involved anytime when you ask.
Thank you so much. And, Banner has a brain health registry, which we can post on the link here, but just tell our audience how you get to the brain health registry.
Certainly. So our registry is endalz now.org. So that's endalznow.org. And signing up just takes about a minute. It's name, and basic contact information. And not only will you get some of our newsletters, probably highlighting some of the same topics in a different way that the Being Patient newsletter comes up with, but we connect people to research studies taking place in your community. The choice is always yours whether to participate in those studies, but we're kind of like a research matchmaking service, if you will.
That's great. Thank you so much, Jessica. And if you wanted to see more of this interview, we always upload them to beingpatient.com if you missed any of it. And we will also transcribe it onto our site. And make sure you sign up for our newsletter, because we will keep you posted about other upcoming talks from experts like Jessica to keep you informed. If you have any ideas for talks, or curious or need information, please email us at info@beingpatient.com. Thanks very much for watching.